Welcome everyone. My name is Sharon Rounds. I'm the PI for Advance Rhode Island CTR. And it's my great pleasure today to be hosting one of our monthly Advance RI-CTR clinical and translational research seminars. Today we're very pleased to have one of our distinguished researchers speaking. Alan Rothman is a research professor in the Department of Cell and Molecular Biology at the University of Rhode Island. Alan received his MD from the Boston University School of Medicine. He was a resident in internal medicine at Medical College of Virginia and the Boston VA, and trained in infectious diseases at the University of Massachusetts Medical School. He's been involved with immunology research since his fellowship, focusing on human immune responses to the dengue virus and its effects on the outcome of these infections. He's done both clinical and basic research on the epidemiology, host pathogen interactions, disease pathogenesis, and immunity, collaborating with other investigators in Asia and Latin America. He's had a long-standing program project grant from the National Institutes of Health and has been is really an internationally recognized expert in this area. And I do want to say, Alan may touch on this, but it's my understanding that because of climate change, that dengue virus is becoming much more widespread in the world and an increasing international problem. So we're thrilled to have you here today. And Alan, take it away.
Well, thank you very much. Let me just confirm you can hear my voice. Okay, great. So thank you again for the invitation to speak. Thank you also for the very kind introduction. Let me get my cursor moving. Okay, so here are my disclosures, and let me just see if I can get a laser pointer. Sorry. Oh, well. So, so let me begin by introducing some general concepts of dengue to bring everyone up to speed. When I started working on this disease, it was certainly not one that would be part of common conversation. I find it comes up much more now. People are much more aware than they used to be about dengue, but even as the decades have gone by, we think of this as an emerging virus disease. It has been estimated that there are as many as 400 million infections with dengue that occur every year, and the trend has been not particularly favorable. This is the number of cases reported to WHO by the region. I would point out that the green color here is the Americas region, which has been very much affected by dengue. Dengue is a mosquito-borne viral disease, and the mosquitoes are Aedes mosquitoes. This is a picture of Aedes aegypti, the principal vector of dengue, as well as the principal vector of Zika virus and chikungunya virus. And these are mosquitoes that are widespread in warmer parts of the world. As Sharon mentioned, the warmer parts of the world are expanding, and so the expectation is that the range of the mosquito and correspondingly the areas of the world that are at risk for dengue are going to be expanding. The numbers that we throw out currently are about half the global population is living where there is significant risk, with most of the burden of dengue in Southeast Asia and the Americas. Like many viral diseases, dengue has a wide spectrum of presentation. Of those 400 million infections, we estimate that at least 3/4 of them are actually inapparent, that if they cause any symptoms at all, the symptoms are trivial and never come to medical attention. And the most A common presentation is a mild febrile illness that will go away after a few days. But what makes dengue really interesting is that a small percentage of individuals, estimated somewhat less than, certainly less than 5%, perhaps less than 1% of infections, produces a very severe syndrome that's referred to as a viral hemorrhagic fever. And that's a bit of a misnomer. It's really, as I'll discuss a little bit further, what we call a plasma leakage syndrome. And the plasma leakage syndrome is characterized by fluid leaking out of blood vessels. Fluid goes into the chest cavity and the abdominal cavity, and correspondingly, the blood part of, or the liquid part of blood is reduced in volume. You see actual hemoconcentration, which is what's being illustrated on this graphic here. And when this happens rapidly, people can go into shock. Dengue, the disease, is caused by a virus that has been named dengue virus. It is a member of a group of viruses, the genus Orthoflavivirus, newly named. And this is a sort of a phylogenetic tree of orthoflaviviruses showing you really 4 dengue viruses that we refer to as serotypes. They're considered all the same species of virus, and they have close cousins, including Zika virus, yellow fever virus, West Nile virus, things that people have heard about. Dengue, all 4 viruses behave more or less similarly in terms of illness and their pathogenesis. They are viruses that tend to infect monocytes and macrophages. They have a relatively simple genome where they produce 10 proteins, 3 structural proteins that form this virus particle, and 7 proteins that are produced inside cells called non-structural proteins. An important part of this idea of 4 serotypes is that they have partial immunity between them. So there's antigenic similarity, cross-reactivity of immune responses, but protection is largely serotype specific. And so you can get dengue more than once in your lifetime, but typically you won't get the same serotype again later on in your lifetime. If you get infected with dengue again, it's going to be a different serotype than you had the first time. And let me get my cursor going again. And the other thing about dengue is that this progression of the clinical illness follows a very particular pattern. So on the left graphic, I show a clinical presentation as it evolves over time. And on the right, these are sort of immunologic and virologic events that correspond to those. So the symptoms of dengue usually start with fever, headache, achiness that goes on for several days that we refer to as the febrile phase. And most people feel better at the end of this period of time, and they recover, and there are no complications. But there's this small percentage of individuals who go on to a more severe course. So when the fever drops, they have a relatively quick decline in platelets count, and they begin to get plasma leakage, causing this hemoconcentration. And it produces what we call the critical phase. So this period of time at the end of the febrile phase, and a period of time that lasts only about 12 to 48 hours, where this plasma leakage can occur. And if plasma leakage is severe, blood volume can drop very rapidly and people can go into shock. And that's the principal cause of problems from dengue. In other cases, if people can get to medical attention and have their fluid volume restored, what will happen is this critical period will end. The third spacing of fluid will stop and people will start to recover and then resorb that fluid, and recovery will take a few days when people mostly do okay, but they can get fluid overload if they have too much of this third spacing that takes place. And these clinical events correspond to certain virologic and immunologic events. We know from limited studies that there's a period of time where the virus replicates peripherally, probably at the site where the mosquito bites, and then travels to regional lymph nodes before viremia occurs. And viremia really corresponds to this febrile period of time very closely. Viremia can start a little bit before, but generally ends at around the time the fever ends. The viremia is associated with activation of both non-specific as well as adaptive, so innate and adaptive immune responses, as mentioned here. And it's the clearance of viremia and the maximum activation of the immune response that tends to correlate with that critical phase when people are at risk for plasma leakage. Another important feature of dengue is because of this partial cross-reactivity between the four serotypes, you can look at the course of an immune response and you can see a difference in adaptive immune responses between the first time you get dengue and subsequent times that you get dengue. You have pre-existing antibodies and memory lymphocytes that are reactivated during the secondary infection. So a lot of the concern about dengue and the research efforts understanding why, as with other virus infections, why do some people get either no illness or mild illness and a few people get a very severe illness. And so the thinking about dengue is you have this sort of distribution of disease severity where only a very small population of individuals at the high end of the curve get sufficient disease to reach the plasma, what we call the plasma leakage threshold. So the events are enough to produce clinically relevant plasma leakage that then produces these severe manifestations. And different factors will affect this distribution of disease severity in the population. And those factors can include things related to the virus. So we know that dengue viruses do differ from one another in their likelihood to produce severe disease. Nowadays, we think of this as a relatively minor factor. Much more is dependent on the host. And there are certainly certain innate characteristics of the host that are important. Host genetics contribute to this, but the most important contribution relates to things that we acquire over time, in particular, immunity. And this is work that goes back now, more than almost 6 decades. Seminal work by Scott Halstead in Southeast Asia recognized that the severe form of dengue, the plasma leakage syndrome, was much more likely to happen the second time you get dengue than the first time. So it would happen during the first infection, but pretty rare, as shown in this graphic on the right. And it would be somewhere between 15-fold or 100-fold more common the second time you get dengue. And so the thinking about dengue is related to what is it about the adaptive immune response that explains this tendency towards a plasma leakage syndrome. So this slide sort of gives a model of dengue pathogenesis and how second infection would contribute to that. So again, these are viruses that predominantly infect monocytes and macrophages, and they replicate in those cells and they activate innate and adaptive immune responses. The plasma leakage syndrome itself relates to dysfunction of the vascular endothelium, and there's relatively little anatomic abnormality. So we think this is really a functional change in the vascular endothelial cell that is transient and likely driven by circulating mediators. So when you have infection of cell, the cell will respond with producing cytokines, and the immune system reacts. It also contributes to the cytokine production. And in a primary infection, this is usually not sufficient to induce plasma leakage. In a second infection, you have two key factors that differ. You have the pre-existing presence of antibody, and you have the pre-existing presence of memory lymphocytes. The antibodies are important because the cross-reactivity allows some of those antibodies to bind to this new virus that you're infected with, producing immune complexes that interact with the immune system in a different way than in the primary infection. So one, they can activate new pathways like complement, but also these complexes of virus and antibody are much more efficient at entering cells and at initiating the process of replication in the target cells for dengue. So you have this process that we refer to as antibody-dependent enhancement of infection. It's well established in the laboratory, and circumstantial evidence points to this as a key component, and I'll talk about that more in a moment. Second factor is you have these memory lymphocytes that are able to be activated more readily into second infection. They activate it in a higher frequency, and they produce a different pattern of cytokines. And so one component is that you're going to change the cytokine response for a given level of viral load, and that's thought to contribute to plasma leakage. So this is sort of the pathogenic process that people think of in relation to this phenomenon of plasma leakage syndrome. And we and other people have spent a lot of effort to study people that are presenting to the hospital with plasma leakage syndrome, to characterize these immune responses. And I don't want to summarize that work. I want to summarize a different aspect of our work, but just very briefly to summarize where we stand from that work is we know that plasma leakage relates to high viremia, that those viremias reach their peak very early in infection and activate a whole multitude of immune responses. And what that taught us at that point is that even if you look at the very earliest point when someone's presenting to the hospital, that the factors that are going to determine disease severity are already established by that point. So that it was the events that preceded that really were determinative of how sick someone was going to get. They don't have plasma leakage yet, but the stage has been set for that to take place. And so we recognize that the idea of studying people who are presenting to the hospital had certain limitations. You're missing the multitude of, or the majority of infections that are taking place with either minimal or no symptoms. You're missing all of the events that took place prior to the peak viremia when you set the stage for that occurrence of plasma leakage. And finally, you don't know what immune responses existed. And we know from what I've told you so far that the pre-existing adaptive immune responses were critical to the events that were going to take place during that early phase of infection. So looking at these phenomena, we set out to conduct studies to get at these risk factors that determine which individuals are going to go on, because that's what we saw as a key part of what you might want to intervene at to prevent severe disease from occurring. And at this stage, we had already been working with our colleagues in Thailand, and we looked for an opportunity to extend that work and took advantage of resources in a rural part of Thailand that I'm going to focus on for most of my talk, Kamphaeng Phet. So Kamphaeng Phet is a province in north-central Thailand, as illustrated here. This is a map. It's sort of divided by the key river there. This is a Google Earth image of Kamphaeng Phet province that sort of fills this entire area. You can see it's a very rural part of Thailand. In comparison, this is Bangkok, showing you the extensive urban development in the capital city. So this is Kamphaeng Phet, very rural. There's just this main capital city where most of the development take place, and that's where a key resource that I'm going to talk about has been located. Kamphaeng Phet is sort of historical significance in Thailand. It's got some really beautiful natural wonders, and the population there is very it's kind of old-fashioned. They live in these sort of very more traditional Thai rural settings. The province is mostly an agricultural-driven province. There's a little bit of industry present. And again, most of the population lives outside of urban areas. And we were able to take advantage, I should say, of resources that were already present. So as with most of Thailand, the government provides most of the health care. There are a series of public health centers distributed through the province that provide primary care, and then more severe cases are referred to the provincial hospital. Fortunate for us, the U.S. Army had been having an established collaboration with the population of Kamphaeng Phet and with the staff at the Kamphaeng Phet Provincial Hospital, and they have had a research center located on the grounds of the hospital that we were able to utilize for this clinical research. And this is the Kemping Pet Aframs Virology Research Unit that you see here, and this is the staff that is working there. So CAVRU, what we call that unit, has been conducting studies. They receive samples from the provincial hospital. They perform diagnostic services for the hospital detecting dengue cases. And so we had a lot of information about dengue in the province. This is showing you the sort of epidemiology of dengue in the province, cases reported, those in the capital. This is the location. So the unit had the capability of mapping the location of all of the defined cases in Kemping Pet, and we're able to analyze the viruses and determine the distribution of dengue serotypes in the province over a series of years. And as is true of any dengue endemic area, you see introduction of viruses, you see replacement of the dominant serotype over every few years. With so, for example, in blue you see dengue 1 being the predominant serotype in here 1997, and again 5 years later, and again another 5 years later. So this sequence of distribution of viruses is very common in endemic areas, and this was the setting in which we sought to conduct our research. We took a very straightforward cohort approach to this. So we conducted a prospective cohort study. Dengue in Thailand is primarily a disease of school-age children. That's the population that's most susceptible to dengue. And so we started by enrolling people in schools. So we took the province, we identified schools that had ready access to transporting things to the CAVRU laboratory, and we would enroll children, we'd collect blood from those children, and then we would conduct surveillance. We'd do two types of surveillance. So during the dengue transmission season, we would check for any school absences or febrile illnesses, and we would draw blood from children who had either a school absence or who had fever, I should say, to look for cases of dengue. We also drew periodic blood samples so that we could do antibody testing to identify dengue infections that were not picked up through the active surveillance. So through this process, we would be able to identify children with symptomatic dengue and get their viruses. And we'd also identify children who experienced dengue but didn't develop symptoms during this period of time. And we sort of expected that we would detect these two populations, but we found some things we didn't expect exactly. And so this is sort of one of the first things that we were surprised by in our studies. So what I'm showing here is the experience of dengue broken out in these different schools. So again, we have this province and we enrolled children at 12 different schools. And I'm taking, I think, a sampling of those schools, 7 of them, and I'm graphing the percentage of children that experience dengue during any given year, the ratio of subclinical infections to symptomatic infections. And then on the right, I've picked 4 schools to highlight the sort of number of cases of each serotype of virus, where each of these colors is a different serotype of virus. And what we found that even though the province reported these broad patterns, the experience at the school level was markedly different, and it differed from school to school. One school would have a very low year followed by a high year, and a different school located very close by would have the opposite experience in terms of both the incidence, the ratio of subclinic to symptomatic cases, and even which serotypes were being circulated during this period of time. And this showed us that thinking of things at the provincial level was just wrong, that there were a lot of more interesting and complex interactions going along at the village level, or at least potentially at the school level or the family level. And that's what sort of led us to further things. Oops, sorry. Let me get that to advance. So by having this unit of the school with different epidemiology, where again we could start to tease out what factors would affect the outcome during any given year. And this is a set of epidemiologic parameters that we compared. So that again, this is testing at the school level, looking at the incidence in the current year, the proportion of each serotype, and the number of serotypes that were detected in that school. And we also looked at the effect of the previous year. And one of the things we found was that in any given year, the more cases you had, the less likely it was to be subclinical. So more of those would be symptomatic infections. Dengue 3 seemed to produce a little bit more than other serotypes. But what was interesting is that the incidence in the prior year had the opposite effect. So if you had one high year, you were much more likely to have predominantly subclinical infections in the subsequent year at the same school, indicating that there was sort of a progression of things happening in this population over time. One of the factors is the length of time between infections. So in this cohort study that we conducted over a 5-year period, we were able to identify a certain number of people who had more than one infection, and we could study the time interval and how that related to the outcome. So this is for all of the subjects, and this is particularly for those subjects in the cohort who, at the time they were enrolled, did not have any dengue-specific antibodies. And that would suggest that the first infection was their first dengue infection, and the second one that we detected was their second infection. And what we saw is that the shorter the interval, the more likely the infection was to be subclinical. So there was some degree of protection that was lasting for a period of about a year, where people would get infected, but they would be protected, relatively speaking, from the severe form of disease. And we have a primarily an immunologic bent, so we did a number of studies looking at immunologic parameters. We studied things that you would expect to study. And I'm going to go through this fairly quickly because this is relatively old data. But for example, we studied neutralizing antibody and how that related to the clinical presentation of disease. And what I'm showing you here is we selected people who had symptomatic infection so that we knew what virus they had. And then we could compare the antibody response in people with different levels of disease severity. So this is hemorrhagic fever. That was the most severe form. These are people who had milder illness, but some of them were hospitalized and some of them were not hospitalized. So this is sort of the progression of illness severity. These are in fact, the neutralizing antibody responses to the virus that the patient was infected with. So one of the things we learned through this process is even if you had neutralizing antibody, you could be infected with the dengue virus. It didn't provide absolute protection against infection. It did seem to give some protection against severe disease, at least for dengue 3, but that was not true for all of the different serotypes. And so this is the kind of complexity of responses we observed. We looked at this issue of antibody-dependent enhancement of infection. We used a laboratory measure to see how much enhancement took place. This is a very complex slide where we, again, had people with different kinds of virus infection, and we looked both at the level of virus they had in the blood as well as the severity of disease. And the short version is we didn't see any correlation. So the presence of this phenomenon of antibody-dependent enhancement wasn't able to explain which people got sicker and which people got milder illness, at least among people with viremia. Now we also began to look at this issue of subclinical infection. So we looked at immune responses in people who had subclinical infection and compared them to the symptomatic group, because we didn't necessarily see that much difference between severe disease and mild disease, but all of those people had a symptomatic infection. And here's an example of an immune response, in this case a T-cell response measured by flow cytometry, that was significantly higher, in this case in patients with subclinical infections. We used several additional measures of T cell response. In this case, we took blood. So all of this was done with blood that was collected before the illness. So we're now trying to look at how the pre-existing adaptive immune response would predict disease. We found that the production of some cytokines by those blood samples was correlated with subclinical infection, as shown here, whereas other cytokines, IL-6 and IL-15, shown in this slide, were produced at higher levels in people who had the more symptomatic infection. So through this process, we're able to identify the idea that some immune responses could make it less likely that you would get sick, and some immune responses made it more likely that you would get sick, in particular severe dengue disease, plasma leakage. So this is sort of the thinking about what's going on in this cohort, that you had this cohort of individuals, and the first determination was going to be whether they were exposed to dengue. If they were exposed to dengue, did they get infected? So some individuals might be bitten by a mosquito carrying dengue but not get sick. If you got infected with dengue, did you get any illness? And then if you got illness, how severe was the illness, mild and severe? So you saw in the previous studies, we would sometimes compare individuals who had mild and severe dengue. In other cases, we were comparing people who had infection without symptoms to people who had infection with symptoms. And what was really challenging to us is to think about these other different outcomes. So there was going to be some people who were being exposed to dengue, being bitten by mosquitoes, but not having infection. And that really was an interesting population. That's the kind of immune response you're most interested in, because the goal of vaccination is to prevent infection completely. And so the next phase of this was to expand into trying to capture some of those other scenarios. So during the next iteration, we continued doing the school-based cohort studies, but we added on a component that we call a cluster investigation. And that's what's illustrated in the graphic on the left. So there would be a case of dengue that would be identified in our cohort, the index case, which is shown in this example here. And then we would count off houses within a certain circumference of that the index house. And the logic there is that Aedes mosquitoes don't like to fly very far. They tend to live around houses, and they move relatively short distances over time. So it's considered relatively unusual for an individual mosquito to fly or to circulate over a distance of more than 100 meters. So we were looking at how the location of other individuals would represent risk. So we'd have that index case, and we'd enroll individuals in a certain number of neighboring houses, and we'd look for infections in those additional individuals we were enrolling. And sure enough, we could identify a lot of transmission happening around houses where there was an index case, what we call a positive cluster. And there would be highly variable. Some of these clusters would have infection rates of 60% of all of the susceptible individuals, of the children living in this area, whereas others would have essentially no additional cases identified through these clusters. But by enrolling these individuals, we're capturing infections at a very early stage with an even higher chance of capturing subclinical cases. And one of the things this allowed us to do was to look at the antibody responses in some of these individuals. And we happened upon a scenario where there were individuals who, at the time we drew their blood, there was no infection taking place. But when we went back 2 weeks later to get a second blood sample, they had gotten infected with the virus that was circulating in that area. So here we have a group of individuals who were in these cluster investigations who initially were negative, but then got infected with dengue 4, and we looked at their neutralizing antibody response, and we compared them to a group of individuals in these same clusters that did not get infected during this 2-week period. So what these graphs are showing are the neutralizing antibody titers to the 4 dengue serotypes, as well as the Japanese encephalitis virus. So the rightmost bars is Japanese encephalitis virus, another flavivirus that circulates in the area. One of the things you notice here is that for dengue 4, none of these infected individuals had pre-existing neutralizing antibody to dengue 4. So by going into these clusters, we're really able to define this population of susceptible individuals, whereas among the uninfected individuals, most of them had neutralizing antibody to dengue 4. There were a few individuals who didn't have neutralizing antibody, but somehow didn't manage not to become infected. We of course can't know for sure that they were bitten by an infected mosquito. The situation is, as always with dengue, got a little bit more complex when we examined a wider population. So this is a similar graph, but studying dengue 2, and the graph is organized a little differently because we had to conduct the study differently. So the group of individuals that had gotten infected with dengue 2 is in this rightmost column. These individuals had a wide spectrum of ages. So some of these last 3 were adults. These 4 bars represent neutralizing antibody titers to the 4 serotypes. So blue is dengue. These additional blue bars were additional dengue 2 viruses that we checked. And so the key element is the young individuals who got infected did not have any dengue 2 antibody starting out, whereas their age-matched cohort in the same clusters did have neutralizing antibodies to dengue 2. When you got to the older population, it didn't fall out quite that well. Even the people who got infected had the detectable neutralizing antibody and really not distinguishable from other individuals in these cluster investigations. So hinting at, again, a protective effect, but not an absolute protective effect, and it's a little bit more complicated. We have, in these cohorts, we're collecting a lot of samples over time, and so one of the main areas we've been exploring with some biostatistics colleagues recently has been to take advantage of this large set of samples in these individuals by modeling the antibody titers over time. And I'm going to focus on panel A here. These are 3 examples of individuals showing their antibody responses over time. And by looking at this progression, what they were able to model is not only the infections that were detected, which are these blue lines, but we're able to pick up infections that hadn't been detected through the normal surveillance process, subclinical infections in these individuals. So we're able to assemble a larger picture of symptomatic and subclinical infections in these individuals and to model what the antibody response was at the time people were being exposed. And so this is the result of modeling the effect of antibody titer. This is looking at how antibody titer affects the likelihood of infection, the likelihood of being symptomatic, the likelihood of hospitalization, and the likelihood of having the plasma leakage syndrome. What you see is for something that sort of straightforward infection or even symptomatic infection, the more antibody you had, the better. The less the likelihood, the lower the probability of getting infection. What was interesting is as you look at the hemorrhagic fever phenomenon, the plasma leakage, this open circle are people who didn't have any antibody. Those would be experiencing a primary infection. And what you see is if you have a lot of antibody, your likelihood of plasma leakage was very low. But it was this window of antibody, sort of low titers, that actually increased your risk of plasma leakage compared to individuals with no antibody. And this is consistent with that phenomenon of the pre-existing immunity triggering the plasma leakage syndrome, and it relies on a critical level of immunity at the time that you're exposed. We have recently been going further to explore this issue of the kinetics of immune response over time. This is a very complex slide that I'm going to kind of summarize and give you the highlight on the next slide. But this is work that was done by Luis Sanchez Vargas in the laboratory at URI, where he looked at T cell responses by ELISpot in individuals who had samples over this 5 years, some of them who experienced a symptomatic infection, some of them who had a subclinical infection, and a group of individuals who hadn't experienced any dengue infection during this follow-up period. And what you can see is there is a lot of variability in this population, and there are no obvious patterns that show up in the population as a whole, but we focused on the issue of what immune response were present either before infection or in the immediate period after infection. And that's what's summarized on this slide. So in the first column, these are looking at 4 different measures of this immune response prior to their infection. And these are the first 3 years after their infection. I'm going to focus on these significant differences here. What we noticed is the people who had gotten infection, by and large, had very low T cell responses present at the time that they were exposed. But the group of individuals who didn't have dengue had significantly higher responses in certain cases. And so this points to T cell responses as potentially limiting the opportunity for infection, giving you some degree of protection. Luis was also very puzzled about these very low responses in the symptomatic individuals, trying to understand how these memory immune responses might be associated with outcome. And so the approach he took to that question was to look at an expansion of this population. So he used cultured ELISpot responses to look at how those immune responses would expand with exposure to antigen. So on the left of each of these graphs are the measures of the immune response in the blood sample collected before infection, and the right bars are the blood sample collected after the infection. The blue triangles are the people with milder illness. Red is people with plasma leakage. These were all symptomatic infections. And what you can see is there was a significantly higher immune response in this cultured assay in the people who went on to have plasma leakage, pointing to immune responses that were expanded in association with plasma leakage phenomena. So, let's see. So, in this kind of final phase of my talk, I want to sort of expand on this to describe where our research has been going to understand this further. So up to now, we've primarily focused on studying the school children, which is the group of population that's at highest risk for plasma leakage. People are in that risk window for only a few years at a time. And what we've observed is that there's much more important information in the progression of infections and the progression of the immune response over time that might be contributing to risk. If you look at a given individual over their lifespan, their risk is going to change over time. They're born typically with antibody that has been passively acquired from the mother that is largely gone by the end of the first year of life. They begin to get their first dengue infections, and they have a more limited immune response that we consider monotypic from that first serotype that we're exposed to. This immune response is present when they get their next dengue infection, which is the period at risk. They now have a broader immune response following that infection that will be present for the rest of their life as they get exposed to dengue in the future. And the outcome and the interaction of those immune responses with the occurrence of infection is going to change over a person's lifetime. So the recent phase of our work has been going into what we consider, what we're really excited about, a study that is looking at the family unit as a whole. So this describes the study. We enrolled families throughout Champagne-Pet province, and we were looking to capture this full range of a person's dengue exposure over a much longer period of time through these different areas at risk. So we enroll the entire family, focusing on pregnant women so that we're able to enroll their newborns. We can follow the newborn then through their first dengue infection, maybe their second one, and we enroll the other members of the family to look at the impact over time. In addition to sort of routine surveillance for febrile illness and for subclinical dengue, if anyone in the family has a dengue infection detected, we sample all of the individuals in that family because we know from the previous studies that the risk of transmission is very intense at that period of time. And so we've been able to enroll a cohort of several thousand individuals. They cover people of all ages. And as you'd expect, people start with, as a newborn, with passively acquired antibody that diminishes over time. And so we have a population of people who are dengue naive. We follow them through their first infection where they become monotypic immune. And then by the time people are in their 30s, people have a very broad immune response reflective of multiple prior infections. When we look at this household phenomena, we found a very interesting observation, which is that seropositivity of one person in the household influences the risk of seropositivity in other individuals. So there's a significantly increased risk that you'll be seropositive if other people in your household are seropositive, reflecting this sort of intensity of transmission around the household. And this relationship is strongest when people's age difference is relatively small, indicating that, you know, when you have people who are similar age, they have a common experience of dengue over time. So we've been able to use this to look at risk factors associated with dengue infection in more detail. And this kind of just gives you a flow chart of infections that we've detected in these households, and then those that we've detected through these cluster investigations centering on the household. And we have been able to repeat some of our earlier studies, again, showing that more antibody protects you from infection, but can actually increase the risk of symptoms when you do get infected, reflecting this risk of secondary infection and pre-existing immunity. We have also been able to show that the attack rate in the household has consequences for the likelihood of people getting dengue in the future. So if you live in a household where most of the people are already immune, and when there has been a lot of attack rate, so here's the level of immunity in the household, and here is what the attack rate in the household was in the previous year, you see that the risk of dengue is significantly decreased by either of these. So we're able to identify this notion of herd immunity at the household level. Presumably, you're reducing the intensity of dengue transmission as a result of those other individuals. So this kind of summarizes the thinking at this point in time. You have an infection, you have a mosquito bite by an infected mosquito. We know that early viremia levels are a critical determinant of disease severity. We have evidence that certain immune responses are more likely to suppress that viremia and give you a subclinical infection. Other immune responses might enhance that level of viremia early, but other immune responses will determine how symptomatic you are for any given level of viremia. And it's the individuals who have the most unfavorable combination of immune responses and predisposition that will lead to this to this rare manifestation of plasma leakage. I do have a little bit to talk about with regard to dengue vaccines, but given the time frame that we're in, I will just simply say that we have begun to look at how some of these play out in vaccines. The AFRAMS lab has had a study going on in conjunction with the makers of the Dengue vaccine, which is based on the yellow fever backbone. It's a live attenuated vaccine. We've been able to reproduced some of our studies in the cohorts, in the campaign pet cohort, in these cohort of vaccinees, and we've been able to look at the relationship of antibody titer to the likelihood of infection and the likelihood of symptomatic infection. And what we do find is when you get the vaccine, the level of antibody you get is predictive of the likelihood of infection. So antibody is protective, but not completely so. So this is the survival curve showing you the sort of gold color. These are people with the highest level of antibody, and the purple is the lowest level of antibody after vaccination. And you can see that the more antibody you get after vaccination, the more likely you are to be protected. So my overall picture of what's going on is you have community issues, viruses get introduced, the intensity of transmission differs, individuals get exposed and they either get infected if or not. If they get infected, they may have various levels of disease. Different factors are going to affect each of these different steps in the pathway. We need to maximally take advantage of information about vaccines. I didn't talk about antivirals, but certainly medical care will affect the overall morbidity. So there are multiple levels where we need to address these risk factors, both for infection and disease. And I want to end by acknowledging the many individuals who contributed to this. My colleagues at URI, both current and former. I want to acknowledge Frank Ennis, my mentor, who passed away this past year, who was really instrumental at setting up this collaboration. Many people at AFRAMS and other collaborating laboratories, the individuals in Camping Pet who contributed to our studies, participated, and the members of the staff who did the work, and the funding agencies that contributed. So thank you very much.
Bravo. Thank you, Alan. That was great. So we have time for a few questions. I think Rahul Abid and I had a mind meld. Rahul is in the Department of Surgery at Brown, and he asks if you see differences in the anatomy of the plasma leakage responses. In other words, there are some organs like the lung and the brain that have so-called tight junctions. And I noticed on your x-ray it was pleural effusion, and I couldn't quite tell how much parenchymal edema there was, but one wonders if there are differences in the susceptibility of the vascular bed to the plasma leakage syndrome.
So certainly, yes, there definitely are, and there's particular features of dengue plasma leakage that are different from other plasma leakage syndromes, including other viral hemorrhagic fevers. So dengue, the most prominent features are pleural effusion and ascites. Relatively little peripheral edema, pulmonary edema, so parenchymal leakage is very uncommon in the critical phase of dengue. What you see in dengue is if people get too much fluid administered, if they get too much third spacing, when they resorb the ascites and the pleural effusion, they can then go on into pulmonary edema. But pulmonary edema is very uncommon in that critical phase of dengue. Brain edema is relatively uncommon. So it's only the worst cases, and most of those have gone through a period of hypotension. So we're never quite sure how much of the additional disease is due to shock, complications of shock as compared to dengue. Now there's hepatic involvement in dengue, but it isn't so much the plasma leakage as sort of parenchymal damage from what we think is direct viral effect. And there are a lot of interesting aspects of dengue pathogenesis I didn't get to talk about, including the role of the NS1 protein. But yes, there's a very interesting feature, and it definitely is organ specific. But the most prominent are ascites and pleural effusion.
That's really interesting. Can you predict plasma leakage syndrome by the pattern of cytokines expressed in the blood, or perhaps by gene transcription responses in lymphocytes. I could see a reason why this might be important if it looked like in the early phase that this person was likely to go on to develop plasma leakage syndrome. You'd want to move them to a tertiary care facility and be prepared to treat them in a very promptly.
Yes.
Any likelihood of that?
So that has certainly been a very active area of work, and clearly, um, individuals with dengue have different cytokine levels, gene expression profiles before plasma leakage is evident by either clinical grounds or radiographic features. The actually using that and applying that has been remarkably difficult. And part of it, of course, is the standardization of assays to prove that and to make them clinically relevant. There's a substantial amount of overlap, so there's a statistically significant association, but to be able to define them carefully enough to use that has been challenging. The hematocrit and platelet count and even AST and ALT are also different. And to be honest with you, up to now, we have not found a particular profile that performs any better than an AST level or a
Right.
platelet count. And so, yes, the answer is yes, but you can also do AST and platelet count, and you got it. You're sort of the same place there. As clinicians, it is interesting how the simple things often are as meaningful and predictive as the really complicated, fancy immunology.
Yeah. And Rahul makes a comment in the chat that in 2023, Bangladesh, which had not previously had much in the way of dengue, had 70,000 lab confirmed cases and 327 deaths, peak occurring last summer when a few of us had the opportunity to visit Dhaka. But as far as I know, none of us came home with dengue. I guess we were lucky.
2023 was a very bad year for dengue worldwide. I mean, it followed several low years, and that is very typical. If you have several low years, which we think relate to, less travel from the COVID-related restrictions, you increase the population of susceptible individuals due to some of the phenomenon I talked about, longer intervals between infections. You kind of hit this magic window where people are more prone to having symptomatic and sometimes severe dengue.
And another question, can you comment on any host factors that are important in this?
So there are certain host genetic factors. Some of the simple ones. So HLA, for example, there are a number of different HLA alleles that have been associated with either increase or decreased risk for dengue. If you think of it from an immunologic standpoint, that makes abundant sense. There's an interesting, so several genome-wide association studies that have been done have pointed to MICB, an MHC-like gene, that is associated with natural killer cell activation as an important determinant. And also there's a phospholipase lipase epsilon. I'm blanking on the name of the gene, but it's a gene that has been associated with plasma leakage syndrome, and no one's quite sure why. There's no sort of comparable data to help us understand its role. Now, there's a further phenomenon, which is you might have noticed on the initial map that Africa is painted as a region of mild risk compared to Southeast Asia or the Americas, and some of that is due to missing data. But there's this very interesting phenomenon if you look at places like Cuba, Brazil, that individuals of primarily African heritage seem to have a lower predisposition to severe disease. And this is a phenomenon that there's circumstantial evidence for, not understood, but again, it does point to this issue of certain innate host features that could be related to outcome that we don't really understand yet.
Oh, that's terrific. Well, thank you very, very much. I just want to point out that this monthly conference next month, we'll have two of our CTR awardees speaking, Taylor Von Ash from the School of Public Health at Brown, and Louisa Thompson, who's in the psychiatry department, will be discussing their very interesting and innovative research projects. And Dr. Rothman, thank you once again. And we look forward to seeing everybody again next month. Thank you. Bye-bye.